Yes, the management of high-risk myelodysplastic syndromes is challenging because we don't have an awful lot of evidence. That's one of the problems. In contrast to the large AML trials, there are high-risk MDS patients buried in the AML trials, but they're not very representative of the general population of high-risk MDS. So this is a real issue. We've attempted in recent years to try and create guidelines, international guidelines. So a group of colleagues and I have done both European guidelines and transplant guidelines to try and work out how best to manage patients in transplant and non-transplant setting. So with patients above 10% blasts, they're often incorporated into AML trials. They're often treated like AML historically, but now we have better evidence for the use of azacitidine. So routinely we would use azacitidine in those patients, and survival benefit is generally touted in most of the trials for azacitidine. You can question some of those data in the real world setting, but it's become the standard of care. There is a role for intensive chemotherapy potentially in that population, particularly if you're considering getting a patient to transplant, if they're hypercellular, particularly if they also have genomic mutations that might label them closer to AML than to a sort of more difficult MDS population. So we do try to stratify patients by genomics, by cellularity, by blast percentage before we make decisions about treatment. There's a couple of subgroups where it's really difficult to know what to do, particularly if they're transplant eligible. So less than 10% blasts, but with an excess of blasts, we still don't know whether we need to give them prior treatment or take them straight to transplant. Our European guideline and transplant guideline suggests going straight to transplant, but I think that's relatively weak evidence base. And then there's patients who don't have blasts at all, in whom, again, they're high risk, but we don't know exactly whether we should give them prior azacitidine or transplantation. So these are areas where there's not a lot of trial activity either, unfortunately. There's a study in France looking at a kind of intermediate to high risk MDS group in the context of prior treatment versus no treatment plus transplantation. We'll wait and see if that actually produces any positive outcomes. But it's a difficult group, and it's always been pretty unclear exactly how to manage it. But I think in general terms, we try and manage it more like AML if it's high blast percentage, more like MDS if it's lower blast percentage. But we'll have a healthy debate this afternoon and take some cases and try to make some sense of how we manage these patients, but I wouldn't pretend it's easy.